Okay, we are live. I'm sharing what I'm sharing. And, okay. So we already learned the basic, and I'm thinking I'm going to go. I was looking at some other notes. I'm going to go over, after we get done, I'm going to go over the nephron again because I looked at other exams from other professors before me, and they went over that part. So I'll go. Well, actually, we can go back to it. Let's go to this thing. So let's go through the structure of nephron, because of course we already know this part of the nephron, and all of this is microscopic. There's tens of thousands of them in the cortex, which is the outer region that has all the arteries and veins of your kidney. So the first part, dirty blood, for lack of a better term, is going through here, and that's your glomerulus. That's the first part. And that first part, the glomerulus, that's where all the filtration happens. And then after it goes, once the blood gets filtered here in the glomerulus, it goes through this thing called the Bowman's capsule. And Bowman is spelled like it's, like it sounds, B-O-W-M-A-N. And after the Bowman's capsule, you go through a proximal convoluted tubule. And all that it means is it's proximal, it's close by. And if you have a proximal tubule, you have to have a distal tubule. Now, in between the proximal and distal tubule, you have this thing down here called your loop of Henle, which of course, if this part of the loop is going down, that's called your descending limb. This part of the loop that's going up, it's called your ascending limb. So what's important about these parts? Well, overall, this is for the function to make urine. It filters the blood here at the glomerulus, at this tuft, or this group of capillaries. Then it goes into the Bowman's capsule, proximal convoluted tubule, descending limb of the loop of Henle, and Henle is spelled H-E-N-L-E. And then you have the ascending limb of the loop of Henle, and then it goes into the distal convoluted tubule. After the distal convoluted tubule, it goes into a collecting duct, and collecting duct into your pyramids.
Is that a pathway you want us to?
Yeah, that's a pathway. And if you look at the next slide, look familiar? Yeah. We talked about this pathway, and then I looked at these notes as well. They want us to know this pathway.
Okay.
So if you look at it for words, you have glomerulus, which is the capillaries. Then it goes into the Bowman's capsule, proximal convoluted tubule, then the loop of Henle, which has a descending limb, and then an ascending limb. Then if I have a proximal convoluted tubule, I have to have a distal convoluted tubule, and then to the collecting duct, and then it goes down, the pyramids. It's missing the pyramids here. Pyramids, minor calyx, major calyx, renal pelvis, and then the ureter. So think of this, all this stuff up here, right? Nephron, glomerulus, Bowman's capsule, proximal and distal convoluted tubule, and your loop of Henle. Think of all of that. That's the nephron. That's microscopic. And then from the pyramids to the collecting, from the collecting ducts to the pyramids, minor calyx, major calyx, all the funnels, think of that as what?
Urinary.
That's the urine side, that's the drainage system. So
this happens before the urinary?
Yeah, because I have to filter the blood first, and then to get urine, which is down here. Oh, and urine is simply the byproduct of that filtration. Anything that's extra, which includes water, nitrogens, and salt and anything else that's extra. So what kind of questions could I ask? I could ask about the nephron. Is the glomerulus part of the nephron? Yes. That's where there's filtration. Where does it filter into? It filters into the glomerular capsule. What's the first tube you go through? Proximal convoluted tubule. Now, the loop of Henle, or the descending and the ascending loop, the loop of Henle is important because that's where water and salt get to be absorbed. So think, doesn't matter, you don't need to memorize which is the ascending or descending limb. Just know that the loop of Henle, think water and salt. That's it. Beautiful, both A and B question. And then, of course, if I have a proximal convoluted tubule, I have to have a distal convoluted tubule into some sort of collecting duct. And from that collecting duct, you can insert here in your notes, before the minor calyx, we know that there are pyramids before the minor calyx. Major calyx, renal pelvis, and of course, the ureter, which is the tube that goes from your kidneys to your urinary bladder, which is the temporary storage. And then you have a tube from your temporary storage to the toilet, which is your urethra. So this is a good thing to look at.
You said nephron loop filters salt and water?
Yeah, just think water and salt go in and out of that loop. And for future training, you're going to talk about why. And it's called your countercurrent.
Okay.
But that's too complex for this particular lecture, and we're already learning a lot of things already. So just know that water and salt gets to play around in here. So if I can ask you, where does water and salt go in and out of the tubes? And you'll tell me loop of Henle, which is this thing. I could ask you, where does filtration happen? And you'll tell me glomerulus. Where does the filtrate filter into? Filters into this space called your Bowman's capsule. After the Bowman's capsule, it goes into the proximal convoluted tubule, into the loop of Henle, where water and salt go in and out, and then the distal convoluted tubule. And by that time, this is already fully formed urine into your distal tubule, into your collecting duct. And then just imagine if you had like 30,000 collecting ducts that are microscopic. They're all going to empty now into your pyramid, which is just the upside down funnel, and the beginning of the funnel structure, which is here.
Wait.
Minor calyx, major calyx, renal pelvis. And it even says here drainage system.
Glomerular is the filtration?
Yeah, glomerulus is the filtration. And think about it.
Okay.
If this is the nephron, it's got to be the first thing that I do,
Yeah.
because it's all the blood. And the first thing I got to do is I got to filter everything. And then once I filter everything, I got to then transfer whatever filtrate, which is urine, around. And then, of course, in the loop of Henle, the urine gets messed around with decides whether do I need to keep the water or do I need to get rid of it? Do I need to keep the salt or I need to get rid of it? And remember, we had things like ADH, antidiuretic hormone. Antidiuretic hormone tells my loop of Henle to do what? Don't throw out water. Keep the water. I need it. Right? Well, there's other hormones and other things that's telling you keep salt. And remember, wherever salt goes, water goes. So loop of Henle, salt's going into it. So what has to go into the loop of Henle as well? Water. So loop of Henle, ascending and descending loop. That's a nice both A and B for salt and water. And the other tubes are just tubes.
So loop of Henle is the loops, and then you said, what's the Bowman's capsule? The glomerular?
The glomerulus is this little thing of capillaries.
Oh, that's the Bowman's.
That's the filtration. Think glomerulus, filtration. And whatever you filter, you know, like when you filter coffee, it's got to go somewhere, the fluid, right? So the fluid is where? It goes into this Bowman's capsule. And then it's got to go in a tube, the proximal convoluted tubule. And then it's got to go in another tube, loop of Henle, which is where water and salt get to go in and out of. And then by the time it gets to the distal convoluted tubule and the collecting duct, that's already what? Urine. And then after that, it goes into the urine part of the show, which is your medullary. And what was the first thing that we talked about that this particular chart is missing? It's missing
The artery.
the pyramids. So I have my pyramid here, minor calyx, major calyx, renal pelvis, and then out into my ureter. And then, of course, who stores it temporarily? Urinary bladder. What's the tube that goes out from your urinary bladder to the toilet?
Urethra.
And that's your urethra. Now, don't get your urethra confused with your ureter. Ureter, you got two of them. We got two kidneys, and they're going where? Into your single urinary bladder. But then, of course, you have one urinary bladder. You only have one way out to go to the toilet. So that's your urethra. So this is a good picture. This is a good thing to look at. This is a good thing to look at. And that's your nephron, and that's the process on how you make urine. And we already talked about the JG cells. What were the JG cells? What are they going to do? You're going to think what? Blood pressure and sodium chloride. And that makes sense because wherever salt goes, water goes. And if I have too much salt, what's going to happen to my blood pressure? It's going to go up, up. If I have too little salt, my blood pressure will go down. And that's the JG cell. It's located right here. And it makes sense because this is where all the blood's going to filter. So who better to monitor my blood and my blood pressure right there, right at the level of filtration? Because whoever built us pretty smart. So we already talked about glomerular filtration. You heard that 5 times. So if ever I ask, what is the part of the nephron that does the filtering? You'll say glomerulus, right? And that's where things get filtered. And then, of course, you have reabsorption and secretion. Reabsorption and secretion are just backups to the filtration because this filtration process is not 100%. Sometimes it lets go things that by accident. So let's say, for example, my glomerulus let go too many sugars, and I need to get some of those sugars back. That's where reabsorption happens. Reabsorption is something that I accidentally filtered out and that I threw in the urine side, but I want to reabsorb it. I want to take it back. The prefix re means to take it back. Or let's say my kidney decides, wait a minute, I got way too much salt. I should have threw it out in the filtration process, but I forgot to. So what is my kidney going to do? It's going to do what? Secrete it. Something that you should have thrown out, and it's like a backup. So the primary process of the formation of urine and your kidney is filtration. It's going to filter, right? Keep what good things and throw out extra or bad things. Think reabsorption, think what? Back. I accidentally threw something out, and what do? You take it what? Back. And secretion is the exact opposite. I should have threw this thing out, and I'm throwing it out now. And why the redundant systems? Because your glomerulus is not 100%. It misses things sometimes. Glomerular fenestrae. We saw this fenestrae before. It's just like a filter. You know, a filter's got to have little holes in it, and that's what the fenestrae are. Those were the little striped things on when we looked at the micrograph of the glomerulus. It looked like an oil filter or an air filter in your car, and that's what fenestrations are. It's no big deal. It's just little holes that the thing that you're filtering, which is blood, can go through. And you can see them here. You see them here. See this? They look like little fingers that look like this, and that's what it is. It filters stuff. Now, what's GFR? Don't need to know these numbers. GFR is your glomerular filtration rate. GFR is how fast or how slow does your glomerulus filter things. Hence the term glomerular filtration rate. It is one of the things we measure if we want to find out how well my kidney is doing. And that's called your GFR. And your GFR, if it's not pushing out a certain amount every day, then we can term my patient could have oliguria. And then if the GFR is at 0, that means it's not pushing anything out. That means my patient has anuria. Ooh, the renin angiotensin system. Now, this thing is nice, but it's lacking. So let me find you something that's nicer. Find it on Google. RAA system. And there's this one picture that I almost always use. See if it's here. Yes, it is.
Can you put that picture in the email box you have?
Well, it's on a. This is all recorded.
Okay.
So oh, why is it two commercials? Thanks. All right. This chart right here, it looks quite complex, but if you stare at it, don't you think this part here could be considered one part?
Mhm.
This part here, second part, and then what happens? It's a little bit more complex than that other chart that you have in your textbook. And I like it because this gives an all-around overview on how exactly your blood pressure and your kidneys work together. And I could show you how it generates so many questions. But imagine if you memorize this one chart, then you got like a ton of questions. So right off the bat, the stimulus for the renin angiotensin aldosterone system, also known as your RAA system, is decreased blood pressure, decreased blood volume. And do I have to memorize that? No, because if I don't have enough blood, what happens to my blood volume? It's because of fluid in my plasma, blood volume is going to go what? Down. And if blood volume goes down, what's going to happen to my blood pressure? My blood pressure will also go down. So when I look at all this, 1, 2, and 3, that's all one big picture. Decrease in blood pressure, decrease in blood volume, decrease in if I have a decrease in water, I'm also dehydrated. And remember we talked about wherever salt goes, water goes. So if there's not a lot of water, is there a lot of salt? No. So I also have a sodium deficiency. Now, what other situation could I be dehydrated in? Let's say I poked my patient with a knife. Now, 500 cc's of the poor patient's blood is now on the floor. So isn't that decreased blood volume, decreased blood pressure, or hemorrhaging? So all of this, when you're looking at this, all of this is just actually could be on one big box. Meaning what? Blood pressure is down. So if blood pressure is down, everything else is down, including salt, including blood volume. And that's the stimulus. That's the thing that starts the RAA system. Now, we know that the JG cells monitor what? It monitors blood pressure. We already know that. We also know that the JG cells also monitor salt. So we already now know that the stimulus is what? Decreased blood pressure, decreased blood volume, and of course, decreased sodium, which could be either in the form of dehydration or hemorrhaging. So the JG cells are going to say what? Hey, we need to increase my blood pressure. And in order to do that, it's going to release an enzyme called renin. And you could see the JG cell is, of course, in our kidney. That's why I drew, the author of this drew a kidney. From our liver, it releases angiotensinogen. Now, if you look at the word angiotensin, angio means blood vessel. Tensin means what? To tense. So if I'm tensing out my blood vessel, what am I doing to my blood pressure? Increasing or decreasing? I'm increasing it. So what's renin going to do for my blood pressure? Everything that we're going to be all talking about here is to do what to my blood pressure? Increasing, because the stimulus is decreased blood pressure. So angiotensinogen, we know, is a precursor because it has ogen in it. So angiotensinogen from my liver is going to turn into angiotensin 1. Angiotensin 1 is then going to be converted into angiotensin 2 in my lungs, because that's what my lungs is pictured here. And if you could see here, ACE, angiotensin converting enzyme. So angiotensin converting enzyme is to convert angiotensin 1 and then converts it to 2. And then, of course, what's going to happen? Think the overall goal is to increase blood pressure, increase blood volume. So I could ask you, what's going to happen if I have angiotensin in my system? I'm going to have vasoconstriction of my arteries. What's going to happen to my blood? Will I get more blood or less blood? More blood. If I have tense my arteries up and then I put more blood in the system, what's going to happen to my blood pressure? It's all going to go what? Up. And if you notice, the adrenal cortex and your kidneys mess with sodium, potassium, and hydroxide ion. And all of that is to do what? These two things that will release blood pressure. So what kind of questions could come out? One, it could be a simple, what started this all? Decreased blood pressure, decreased blood volume. What did that do? Who's the first person in the pathway? The JG cells of my kidney. What did they release? Renin. What's renin eventually going to do? Increase my blood pressure, increase my blood volume. I have angiotensinogen from my liver. So what's that going to do? It's going to change into angiotensin 1, which in my lung, because of angiotensin converting enzyme, is going to change into angiotensin 2. And then the overall function is two functions: increase in my vasoconstriction of my arteries and increase my blood volume. So that will all do what? Increase my blood pressure. Now, what if, what is the major problem in this country? Does everyone have hypotension? No.
No.
Everyone has what? Hypertension. So this thing, especially with a hypertensive, is active all day, every day. So what are the two things that we're going to do to mess with blood pressure? Don't you think I have medications that's going to mess with the vasoconstriction of my arteries? You guys may have heard of them. Alpha blockers and beta blockers. They're for, low level hypertension. So if I tell my arteries not to constrict anymore and to relax, what's going to happen to my blood pressure? It's going to go down. How about increased blood volume? We already talked 2 times in 2 different chapters about diuretics. What does the water pill or a diuretic do? If it makes me pee, what's going to happen to my blood volume? Will it increase or decrease if I pee a lot? Decrease. So then if my blood volume and decreases, if my fluid in my body decreases, what's going to happen to my blood pressure? It's going to decrease as well. So you could see the 2 major things that we do to mess with blood pressure. And maybe you heard of this. Have you guys ever heard of ACE inhibitors? That's for more hardcore hypertension. Do you even have to memorize that an ACE inhibitor has a chronic cough? No, because I know my ACE, angiotensin converting enzyme, is where? It's in my lung, and it converts angiotensin 1 to angiotensin 2. And what do we also now know that the kidney does because of this chart? We now know it messes with potassium, sodium, and hydroxide ion. So now it messes with salt, because I know it's about sodium and water reabsorption, right? But what does H plus mess with? What do we know that H plus of the hydrogen ion deals with? Acidity. So who else also controls pH volume in our body? Kidneys. So if I don't have one of my kidneys, am I going to have a problem with hypertension? Yup. Am I going to have a problem with My salt? Yup. Am I gonna have a problem with my H plus, my hydrogen ion? Yup.
Is it gonna double because you only have one?
Yeah, it could potentially, because if you make the other one work harder, then of course, GFR will be slower, everything will, it'll work harder, right? But again, right, things that we deal with when we're in pathology. So as a quick review, what's the stimulus? Decreased blood volume, decreased blood pressure. Who's the first person to react? Kidney, JG cells. Because we know JG cells deal with blood pressure and salt. Then JG cells release renin, angiotensinogen gets released by the liver. Then it turns angiotensinogen into angiotensin 1 in the lungs. 1 turns into 2 because of your ACE, which is your angiotensin converting enzyme. And then, of course, what's the 2 things that are going to happen? Vasoconstriction of my arteries, increased blood volume, and then, of course, increased blood volume, increased blood pressure, and that's the outcome. So anytime you see if my patient has a increase of renin or angiotensinogen or angiotensin or aldosterone, then I know what? My blood pressure is going to go what? Up. So if I increase my RAA system, the final product is always blood pressure goes up. But if my patient is hypertensive, what do I use the RAA system? I start blocking pieces of it, like ACE inhibitor, like alpha and beta blockers here, and diuretics here, to do what? To decrease my blood pressure. And that's exactly what we do in medical management of hypertension. But for the exam, what do you just need to know? What started it? What's the end product? And who are the players in between? RAA, renin, angiotensin, aldosterone. And all of that is to do what? Increase my blood pressure. And you know, if I ask you between angiotensin and aldosterone, who's the one who's going to mess with salt? It's aldosterone. If you look at the word angiotensin, what's angio going to mess with? It's going to mess with the vasoconstriction of your arteries. Because it's angio means what? Blood vessel. Tensin means to what? To tense it or make it tight. So
Wait,
let's take a moment and if you're watching this at home, you pause the video and then do what? Make your own version of this and make it even simpler. And then what do? Then create questions based on it. Question.
liver starts it or low blood pressure starts it?
Low blood pressure is the initial stimulus, but who in our kidney notices the low blood pressure?
JG.
JG cells. Because remember, what are the 2 things that the JG cells always look at? Salt
Salt and water.
and blood pressure.
Oh, sorry.
So if they see salt and blood pressure drop, it's going to do what? Oh, I got to release renin. And then the liver then releases angiotensinogen, and then angiotensin 1 turns into 2 after it goes through the lung. And then, of course, the final product, vasoconstriction of my arteries, increased blood volume. And then if I vasoconstrict, what happens to blood pressure? If I put more fluid in the system, what happens to the blood pressure? It goes what? Up. Okay, so let's take a pause because that was a lot of stuff. But if you look at it, it's what? 1 part, 2nd part, and of course this blue section right here, 3rd part. And what are our 3 hormones that are part of this system? Renin, angiotensin, and aldosterone. And if you look here, where's your aldosterone come from? Doesn't the adrenal cortex look like an A? So, right there. Now you know another function of what my adrenal cortex. What's another thing that the adrenal cortex releases that we already know in terms of long-term stress?
Cortisol.
Cortisol. What does cortisol do to inflammation? Increase or decrease it?
Oh, sorry.
Decrease, because remember, if I give hydrocortisone and you got a lump or bump, what will it do to the lump or bump? It will do what? Get it down. But what will I do if I keep on taking it for a long time? What's it going to do to my inflammation process, which, by the way, is a frontline innate response? It's going to reduce it. And if it reduces it, could I get sick?
Yeah.
Yep. And that's the balance thing that we were talking about regarding regarding medical management. Because yeah, you got asthma, I'm giving you corticosteroids, your asthma is going to get better. But if I give you too much corticosteroids, do you think I could give you pneumonia? Yes, easily. Right? So we're always kind of balancing. So if you look at, let's look at the slideshow again. Why did I, anyone custom? You look at it on a little bit simpler level, right? We already know what liver has angiotensinogen, kidney, right? JG cells. And when I'm looking at this kidney, it doesn't even look like a J. It looks like a J to me. So JG cells renin, right? Angiotensin, angiotensin 2, ACE, that's my lungs. And I like the other one because it said ACE right here on the lungs. And then, of course, what's the end result? Two things, vasoconstriction and what? It goes increase fluid. Now, here's a nice little thing as well. If I want to keep all my fluid, what's got to increase as well? Your antidiuretic hormone, which will also do what? It tells the kidney, keep that fluid. I need it. I need to raise my blood pressure. We already know diffusion and osmosis. They're both passive. They're both from where? High to low concentration. And that's how things go in and out. So here's a nice little picture. Wish they put it a little bit earlier. We already know the glomerulus does what? Filtration, right? Well, you have a tubular reabsorption and tubular secretion. Just know reabsorption is what? I'm taking it back where? Where am I putting it?
In.
Where's this? What's red?
Efferent.
Right, that's a what? That's an artery. So it's got to put it back in the blood. So let's say it's sugar. I accidentally threw it out into the Bowman's capsule. Oops. Let me put it what? Back in. And then let's say something like maybe there's too many nitrogens still in my arteriole. Well, it's going to do what? Secrete it. Throw out something that I should have thrown out the first time. And looky here. Do you see the reabsorption secretion? It happens right at the beginning and right at the end. What do we have at the really beginning of this pathway and at the end? We have two convoluted tubules, one proximal, one distal. And it's convoluted because why? It's this.
Surface area.
It's increased surface area. And also what? Let's say I'm going down that lazy river. I shouldn't have threw it out. So I still have an opportunity to do what? Get off that river. And then let's look at the lazy river continuing on. Let's say I was supposed to throw something out. So I still can secrete something all the way at the very end in your distal convoluted tubule. So again, whoever made us pretty perfect. You have a filtration in your glomerulus, which is imperfect, right? So they built backup systems, secretion and reabsorption. And this is a nice picture on how it does it. And all of that happens microscopically in the cortex of your kidneys, or the outer rim, the outer portion of it. Now, we already know what active transport means. Active transport means what? I am actively pumping things, and we already know that sodium and potassium are part of this whole system. Now, if you see the word pump, that means it's an active transport. And we all know what a pump is, right? You got to plug it into the wall. So it requires energy. And if I'm pumping something, I'm usually pumping against a gradient. So I'm going from low to high. And that's exactly what happens in a pump. So if I ask you, sodium potassium pump, and actually the sodium potassium pump is called sodium potassium ATPase pump. ATP because it requires what?
Energy.
Energy. So if you look at this next one, so the worst I could ask you is your sodium and potassium. Every once in a while, it has to go against the gradient in your kidney. So we have sodium potassium pumps. So if I ask you sodium potassium pump, you'll tell me active transport and you'll tell me what? It requires energy. So reabsorption and secretion require energy. Now, does filtration require energy? If you recall, if I'm filtering something in a cup, right? If you call maybe science class in high school, maybe you went to a chemistry class at another university. I put the funnel in, right? Then I put like the little coffee filter. What do? I just put the fluid in there, and what does it do? It just naturally goes what? Down, because it's going from an area of high concentration to low concentration. And that's exactly what's happening in your glomerulus. The filtration is what? Passive. Your blood pressure should already do what? It's already putting a pressure through so that it goes in. But reabsorption and secretion are active processes. So they require things like sodium active transport, or sodium potassium ATP, or ATPase pump. So that's secondary. But all I'll ask is regarding active transport, two things. Requires energy, and the next one is it's pumping or moving against the gradient. And you see here is just some examples, and they are simplifying the loop of Henle. And remember, loop of Henle, that's where sodium and water are specifically going in and out, and you'll find out the real reason of that in, of course, future lectures.
How come all of these have such specific names?
Yeah, there were dudes and dudettes who discovered it, like Henle and this histologist Henle. There's actually 2 or 3 other tissues called Henle, and the Bowman's capsule. Bowman also discovered a whole bunch of stuff, but Bowman was famous for Bowman's capsule, and Henle he's famous for figuring out the loop of Henle and what they call the water sodium countercurrent. And you'll learn all of that
Which
later.
is the nephron loop?
That you'll learn that later once you
Okay.
start prepping for your NCLEX, and you will hate it once you learn it, because it's a little confusing, but don't worry about it.
Okay.
You will get there when you get there. Now, we already know about secretion. Now, same thing. We now know sodium and hydroxide ion, and of course, potassium as well. So we know that sodium turns on or off things. On. Potassium turns on or off things. Off. Hydrogen ion, is it acid or base? Acid. So now you see the 3 major things, the 3 major ions that if my kidneys aren't working, now my kidneys aren't, if I don't have enough sodium, I won't be able to turn things on. If I don't have enough potassium, I won't be able to turn things off, specifically my heart. And of course, hydrogen ion, I'm going to have an acid-base balance problem. So you could sit there and try to memorize all the things that a kidney does, but because if you look at it like a story, now you can see why kidneys are so important and why I get so bent out of shape when, millions of Americans have to go to dialysis. Because remember, all these extra features of our kidney, does that very expensive Fresenius machine do any of those things? Does that Fresenius machine tell me about my blood pressure? Nope. Does it tell me about any water? Nope. Does it tell me about sodium, potassium, or hydrogen ion? Does it do any acid base? Nope. All the Fresenius machine does is take your blood out, filter it, take out the nitrogenous waste, and then do what? Put it back in. And that's all it does. And that's why it takes 4 hours. Because this kidney that we're talking about, look how long, and we're looking at it in a very simplistic view. So you can only imagine the level of training that the nephrologist has to go through after, by the way, medical school, after internal medicine. They do what? Another 2-3 years. Just for what? Just for the kidney. That's it. Now, we already went renin, angiotensin, aldosterone. We already know what that does. We already know what ADH does. Anti-diuretic hormone. It means what? Keep the urine. I want to keep it. Anytime you see the word natriuresis, that means sodium. Look at the first 2, Na. Na is sodium. All right. So if I have something called cardiac natriuretic peptides, that means what? I know sodium already messes with my cardiac, right? But we also know that sodium also messes with my blood pressure because sodium is part of salt, right? So you have these cardiac natriuretic peptides will also do what? They play around with sodium, they play around with turning your heart on and off. So if my kidneys aren't working very well, you think I'm gonna have some blood pressure and some cardiac problems. You betcha. And this is, what do you call that? This is that ADH, but only thing we need to know about ADH, what does it want us to do? It wants to do what? Antidiuresis. Do not pee. I want to keep the urine. I want to keep the water. Now, this countercurrent thing, I'm just going to briefly mention it.
So Dr.
Yeah, shoot.
Regarding ADH, if it's ADH at the high concentration, is it gonna cause vasoconstriction?
No.
No?
ADH, the only thing you got to know about ADH is what? Has nothing to do with vasoconstriction. ADH is antidiuresis hormone. Anti means what?
No.
Against or no, right? Diuresis means to pee, right? So what does ADH tell your kidneys to do? Don't pee. And if you don't pee, what do? You're holding in that water. Why do we need to hold in that water? Maybe I don't have enough blood volume. Maybe I don't have enough blood pressure, right? And I got the renin, angiotensin, aldosterone system telling me what? Increase my blood pressure. So what's ADH going to tell your body to do? Hold it, right? If I hold my water, my blood pressure will go what? Up. Question.
So what about people who are incontinent?
So people who are incontinent, now incontinence, we're going to talk about that momentarily when we talk about the urethra and sphincters, right? So, but remember, all this stuff happens way before it becomes urine, right? So incontinence is a little bit down the path, but keep that in the back. We're going to talk about that momentarily. Now, that countercurrent thing for the loop of Henle. This is called your loop of, well, this is a thing of loop of Henle. And you can see, well, I don't want to get into this further. Just know that this will be for further training. It's rather complex and it deals with pressure gradients and it deals with tonicity. Just know that in the loop of Henle, right, water and sodium chloride do what? They go in and out of the loop in Henle. And when they go in and out of the loop in Henle, they create this thing called your countercurrent, which is, it just means that goes as you go further down, right? The first part, it likes water. And then as you go further back up, it likes salt. That's the easiest way to talk about it. But for our purposes, for our exam, it's a beautiful both A and B question. Loop of Henle deals with A, water, B, salt, C, both, D, neither. Your answer will always be what? Both. And the countercurrent requires what? Both. What's urea? We already know what urea is. Urea is nitrogenous waste. It is the byproduct of amino acid catabolism, because we know that in proteins, if I break down a protein, I get it. I get a whole bunch of amino acids, and then I have to recycle all that stuff. I can recycle the carbon, hydrogen, oxygen, but many times the nitrogen, I don't need it. So I got to get rid of it. So anytime you see urea, you're going to think nitrogenous waste, and that's why I have to pee. Okay. Now, of course, uric acid. I got to break down nucleic acids every once in a while. And uric acid is also another byproduct. And of course, it also makes sense because the kidneys also mess with what? Acid-base balance. And uric acid is one of those little acids just like lactic acid. But the thing about uric acid is, when you get older, how's your filtration?
Bad.
Bad. Well, not bad, but
Weakened.
it gets not
Less.
so good when you get from middle age onward. So when you get older, what can you get? You can get something called gout. Now, remember we talked about our synovial fluid? When you're young, your synovial fluid is what? It's clear.
Yeah.
It's crystal. And it's what? Loose, right? But what happens if my kidneys aren't so good? And also, as I get older, how's my metabolism? I can't break down that
Slower.
burger anymore, I can't break it down as efficiently. So do you think I can have a buildup of uric acid? And if I get uric acid in my joints, it causes inflammation, even though it's from me. But the synovial fluid is used to what? Being clear and beautiful and pristine. But if uric acid gets in there, I'll get something called gout. And gout affects multiple joints, and it's exquisitely painful. And it comes, and it's definitely related to what? Salts, fluids, and of course, since we're talking about proteins, it's also related to your diet. So when a patient gets gout, it's painful, right? So yeah, you could take a whole bunch of meds and get rid of the pain, but we in medicine like to attack what? The source. So we give you medications like colchicine and allopurinol to do what? To remove the uric acid. But normally, who removes that uric acid? Your kidneys. So that's why you don't see a 20-year-old getting gout. Well, you might, but it's a rarity. You'll see what? 50, 60, 70-year-olds. And you don't want those crystals. They're very painful. And the classic question on clinical is big red toe after you've been to a party. Because what makes a lot of uric acid? Alcohol, specifically beer. And that made me very upset 6 years ago when I was diagnosed with gout. I was like, oh, why does it have to be gout? I was okay with osteoarthritis. I could live with that. I'm okay with that level of pain. But gout, that means what? Should I drink beers?
No.
No, because it will now convert that the alcohol, and it's specifically beer. So you could notice I tried to switch to bourbon, but that also is not a good thing. Now, also another thing is what? Salt. In your joints, if I have more fluid in my joints, remember too much fluid is a bad thing. What's it going to do to my inflammation? Don't you think it's going to hurt? No, too much fluid. Too much will make it what?
Oh.
Hurt even more, right? So you can see now uric acid and urea, major excretion products of what's in urine. Now, what's in urine? What does urine look like? Well, urine should be mostly what? Water. But we have some urea, uric acid. Oh, look, creatinine. Remember that stupid drink that all these like bros in the gym eating all day?
It's the same thing.
It's a simple byproduct of what? Proteins. You want to put on mass? What should you do? Eat proteins. Eat more meats, right? Putting powder into your system will, just like multivitamins, what's it going to do? And you can see right here on this slide, that's what your kidneys do. It's going to pee it out. But every day I go to the gym. Every day I see these dudes mix their little concoctions, and then and you're like, how's this? Why do you eat a steak? It does the same thing, and it tastes way better. So composition of urine should be mostly water and what? Metabolic waste products. Now, should I see anything that I really want? That's why I have reabsorption. Should I ever see sugar in there?
No.
No. If you see excess amounts of sugar, you're going to think, what's too much? Sugar. So could my patient potentially be a diabetic?
Mm-hmm.
And that's called splay. If you ever see more than trace amounts of sugar, I mean, if you're non-diabetic, you can eat a whole chocolate on chocolate lava cake, and it won't come out in your urine, right? But because if you've got a kidney problem, you think you're going to start seeing it in urine. If you're diabetic, you're going to start seeing it in urine. Yes. Another thing that they mentioned here is I see metabolites of proteins. Should you ever see a protein in there? And we already know that proteins, are they small? No, they're kind of big, right? They're like amino acid connected to a whole bunch of amino acids connected to a peptide chain. So they're big. So that too, should I be eating more than 3 grams of protein a day, even if I want to get swole? No, because protein is a big thing. And remember, this is a filtering process. Why would I want to throw rocks at my screen door? And that's what you do when you eat way too much meat. Another thing, do you see fat?
No.
Because fat is like a good thing. But if you see fat in there, what does that say about your blood? You have hyperlipidemia. So you should not see fat in there. So you shouldn't see fat, you shouldn't see blood, right? Oh, what's the only time you should see blood? What's the only time that positive blood and urine sample is normal? Happens once a month. Menstruation, right? So that's when it's always normal. Because when I was teaching clinical, how many times am I like, there goes this pink? And I go, you got your period? Yes. And they go, shouldn't it be pink? Right? She goes, no. Right? Because we were looking at the chart, and the chart says, the chart on the wall says yellow, 95%. And if you're dehydrated, what's the color going to look like? It's going to look what? Dark yellow. And if you drank a ton of water, what's it going to look like? Light yellow, right? But should it be brown or any other color?
No.
No. Also, the smell. It's the urine smell, right? That smell, you don't just say normal. It's called aromatic, AROMATIC. When you get to your clinicals, that's when you describe what normal urine smells like. But let's say my patient is diabetic, you see splay, and you smell the urine, and of course, don't do this. Don't take the cup and do this.
Wow.
Right? You waft it. Yeah, yeah. Yeah. There's always one. You know that. There's always one in the class who goes, it smells like urine, Dr. Garais, but I'll check. And then they do this, put it right up to their lips, like, yeah, it's urine. But please. You do what? You open it, right? You hold it down with one hand, because if I start doing this and I hit the sample bottle, what's going to happen? And again, there's always one in every class. I hear, oh, fudge, but they didn't say fudge. And then there's one. Now, urine is what? A fluid. It's a body fluid. So is it highly infectious?
Yes.
Yes. So be careful. So some of the abnormal smells you're going to find is what? You're gonna smell a hint of acetone. It's going to smell like nail polish. But just a hint of it. You'll waft it. You'll smell what? Pee. But then you're like, why does it smell like nail polish? Just a little bit. And that's acetone. That means my patient is kicking out ketones. That means my patient is a
Ketones or sugar?
ketones. Because remember, sugar doesn't smell. But we also know that if my patient's diabetic, what are they making? They're not making sugar,
Ketones.
right? They're making what? Ketones. Because we're telling the liver, we're telling the body that what? I'm on empty. Because are any of the sugar going inside into the mitochondria? No. So the mitochondria is going, oh, I'm guessing no fuel, empty. Let me send a message to the liver and to the pancreas, glucagon. Glucagon will do what? Break down glycogen. But here's the problem. You've been like this for not 14 hours. You've been like this for 14 days. So now, instead of making sugar, what is your liver kicking out? Ketones. And ketones are neurotoxic. And if I have too much of them, can they end up in my urine? Yes. What's another smell?
Asparagus.
Asparagus, yeah, they have, but that's still normal. It stinks.
Vitamins.
But and vitamins too, because vitamins also, you know it's a central patient. They got wonderful colors. I've seen purple, I've seen mauve. I've
Really?
seen lovely colors, yeah, with multivitamins, right? And then what? And then when you smell it, it smells like what? That vitamin medicine-y smell.
What about fish?
Now, fish, no. Now, if your urine smells like fish, rotten fish that's like hot garbage, summer garbage.
Yeah.
Now, your patient has a what? A UTI, most likely gonorrhea, right? And that is called foul smelling. Do not open the cap. You will smell it on your patient before you even ask them to sit in the stirrups.
Okay.
And especially if it's like gonorrhea or syphilis, they're going to be doing the pelvic inflammatory disease or the PID shuffle. They're going to be like, hey, doc, oh yeah. Because it's what? It's painful. So they're going to knock, and then when they get on the stirrup, like, ah. And then, of course, you do the culture, and it's very painful for them. Yeah, question.
Some diabetics, they have like a citrus fruity smell.
Yeah, it's like, well, don't smell a whole bunch of acetone.
I
when you
mean,
go home.
but
But you know when you smell acetone,
yeah.
does it smell a little bit like
Yes.
yeah.
fruity or pineapple-y? I don't know, just a little bit. So that acetone smell, and it's very faint, but you'll know it. You'll when you waft it, it's there, you can smell it. Now, another one is mousy.
Mousy?
Mousy smells like, you know when you take wet cardboard and you put it outside in the rain,
Yeah.
and then you smell the cardboard like after it rains?
Sure.
That's what mousy smells like. Or it smells like
So,
if
like,
you've ever had a
wet?
mouse, right? That means my patient has an enzymatic problem or some sort of GI problem. So these are some classic things that you're gonna see when you go into clinical. Your question and yours.
What happens if they, yours smells like coffee, like they have heavy coffee drinking?
Well, it could, but I like my students, when I did clinical in the other place, they all tried to do stuff like, Dr. Garais, I ate 20 hour-laters, smell my urine. And I'm like, no, I'm not gonna smell your urine. Are you diabetic? And he goes, no, then your urine should smell what?
No.
Normal. Yeah, no lie. She was sitting there eating now-and-laters, then go, and a whole bunch of fruit juice, and she was like, and she goes, okay, give me the bottle. And I knew something was up because they were all giggling in the back. I'm like, what are they all doing? They were all trying to see. And then another one, she was trying to, what was the, oh yes, asparagus. She was like, I took a whole bunch of asparagus and I ate it raw. He goes, let's see what my urine smells like. But here's also the other thing. If you just ate it that morning, when you're urinating, is that the stuff that you just ate? No, because remember, transit time takes what? Anywhere from 12 to 14 hours. So she's sitting there eating all this stuff. She goes, I ate broccoli, she ate all these green vegetables. And I go, no, we're not gonna, it's good for you, but we're not, but then she came back like 2 days later, came to the lab and goes, come on, let me go smell my urine. Because they were so interested to try to simulate what bad things smell like. But just know these smells, except for foul odor. Foul odor, you'll know from across the room.
Okay.
And it smells like dead, rotten fish, right? And it's rotting, and it's pungent. It's very, and that's how you know it's most likely bacterial infection, and it could be per vaginal or per rectum as well. And of course, you'll learn how to deal with all that. So when you look at urine, you can also look at the volume. It's pretty regular, because as long, have you guys ever did this when you were a kid? I even do this as an adult. I'm admitting a lot of weird stuff that I do. Have you ever pee and then like walk around in the living room and then go, I'm gonna pee again, and you pee just a little bit, then you're like, oh, I'm gonna walk around here, and then you like pee some more, and then I used to wonder, like, does it ever end? It doesn't, because as long as you did what? As long as you have fluid in your system, right? As long as you drank, as long as your heart and your kidneys are still working, you should have what? Urine output. That's why I get really upset with nursing staff when I see that bag dead empty. That means what? And I know that the patient isn't in any renal trouble. That means that particular staff member did what? Emptied it out and did not chart it. And then, and what does that signal to us? Is that potential renal failure? But then my patient doesn't have renal failure. So now I'm gonna work up my poor patient and do all these horrible things to them, just because why? Someone can't follow protocol and look at the bag, right? And know that bag, look at that, 50 to 60 cc's per hour, which is normal for a 70 kilogram patient. So if I tell you to go look at the bag Q2, you should see what? At least what? 100 cc's in there, at least. If I don't see 100, then what do? You got to report it, right? And also, again, I also showed you the physical attributes of urine. So if it looks funky, smells funky, or any of that, isn't that something that you have to include in your charting? How many times I don't get the characteristics of urine? They don't even tell me the color, right? And they don't tell me anything. So how do I know if I see 50 cc's, right? Or how many times I see 50 cc's and it's light yellow? Is my patient dehydrated? No. That means what? Somebody, most likely nursing staff or medical assistant or orderly or whoever, did what? Emptied the bag and didn't chart it. And remember, the medical staff is always doing what? I'm always monitoring what goes in and what comes out. Because if I know what goes in, what comes out, then do I know the hydration status of my patient? Sure. Do I have to do now a CBC and then wait on a lab and then have my patient go through some pain? No. So it goes, all these little things, which when you guys start your nursing, it's going to feel annoying. That's the best word. Like you're like, man, I want to do the really cool things. But in reality, when you're doing bedside stuff, you are doing what? The cool things. You are doing the things that will keep that patient alive and better when they get released. Question.
So, do we need to know numbers for that?
No, never.
Okay.
Because this is not an NCLEX review. But eventually, you guys want to go RN program and then you start studying for your NCLEX. All these numbers, all these pressures, you got to memorize them all. Because a nurse should be able to know normal and able to look at the chart without having to look at the reference values.
So it's not gonna be on the PN?
No, it probably won't be. Like I said, it's been forever and a day since I did LPN prep review. It's been more than 10 years. But the LPN prep review isn't as specific. The NCLEX is highly specific. And it'll give you actual numbers and actual scenarios that the RN has to go through. But again, it's your course versus what? A 4-year, full-blown course. But if you know you're going to be with that person one day, might as well memorize them now. Renal clearance. We already know one kind of renal clearance is what? GFR. So if my patient's GFR is low, what's happening? Is my kidneys doing its job?
No.
No. That means the rate at which it's making urine is not fast enough. But what if the GFR is fast? Right? Don't you think now I have to then look at why is blood going way too fast in my kidneys? Maybe my blood pressure is up. Maybe my heart's pushing out too much cardiac volume. You don't know. So there's some tests. Inulin, creatinine, nice to know. But the one test that's really important is GFR, right? But inulin is nice, GFR, and creatinine. And what we do is we measure the amount of like inulin and creatinine that comes out of your urine, like per hour or per time rate. But the GFR is the best one.
So
Yep.
Sorry, did the GFR really give it its color?
No, it's a GFR. Remember, GFR is only about the what? The speed. Think what it says: glomerular filtration rate.
Right.
How fast? How fast is blood filtering through my glomerulus? But when you think color, you're gonna think what? It either could be because of I drank too much or drank too little, or I took some meds or I took Centrum, because there's also a whole bunch of meds that color your urine. The very classic example is the antibiotic rifampin. It makes your urine bright orange and it stains everything. That's why we tell our patient, like, hey, make sure to wear dark underwear or underwear you don't like. As long as you take this rifampin, it's gonna color your urine bright orange, and it'll color your toilet bowl bright orange, your seats, everything, and it's not good. But if you're on rifampin, that's the least, orange urine is the least of your troubles. Most of the time, if you're on rifampin, you're probably on anti-TB medication. That's what I use rifampin. Yeah, that's what I use rifampin for.
That's also like B12 vitamin.
B12 is a nice, like I mentioned before, it's a nice supplement, but just like all these other things, you have to combine it with food because your body doesn't like pills. It doesn't like powders. It likes what? Food. So if you do the powders, if you do the pills, always know that, hey, what you Google, hey, what foods exemplify vitamin B? And it's what, egg yolks, I think, and I forgot what else is vitamin B. Now we're moving on into our urinary, and give me a couple more minutes and then we'll go on a quick 10. So when your urine empties your kidneys, it goes into ureters. You got your left and right, and both your ureters are going to meet at this nice little muscle in between, and that is your urinary bladder. Now, your urinary bladder is made up of muscle and transitional epithelia. And we remember transitional epithelia from chapter 3, week 2 of last term. That means this urinary bladder can get very small and can accommodate in a 70 kilogram male up to 2 liters, which is a lot. So all of this is made up of smooth muscle. Do I have any control over my bladder?
No.
No. Now it brings to answer your question, Ms. Lewis, about incontinence. Now my bladder is going to what? Squeeze, and just like all smooth muscle, it's going to squeeze what? Rhythmically. So just like when you have that feeling of defecation, you also have the feeling of what? Avoiding or urinating. Right? Now, what happens when it's what? Too much, too many signals? It's what? It's called urgency. So as you get older, like I remember when I was younger, when I was like a kid, like, you know, a teenager, right? I'll just hold my pee all day because I got stuff to do, right? And also, especially when like I'm at meet or I'm at practice, I was on a hardcore team, so you don't want to be the guy who goes to the bathroom because when you get back from the bathroom, they're gonna do stuff to you. They're gonna make you do extra push-ups. They're gonna make you climb the ropes a couple of times. So it forces an atmosphere of what? Don't pee. But now that I'm older, when do I want to pee? I have urgency all the time. And remember we talked about as you get older, do you sleep through the whole night? No. As you get older, stuff that many of you will look forward to, around 3 or 4 o'clock in the morning, you just get up and go, why do I have to get pee? Right? Now, if you are continent, meaning that you could still control your sphincters, right? Then you can go back to sleep, but there'll still be that pressure, wouldn't it? But then when you wake up in the morning, how's it when you urinate? It's like what? It's going to come out like what?
Pressurized.
Pressurized, and it's going to come out what? Painful, and of course, what happens to a muscle if I keep on stretching it and shrinking it, stretching it, shrinking it? It's going to have a spasm. So then that's why, like, you know, maybe you were at the county fair or maybe you were at a music festival and you didn't want to go in the porta potty, right? So what happens when you finally go? It's going to spasm, and that's not a good thing. Now, the urinary bladder has to be what? A temporary storage. So once you feel the urgency, you should what? Go pee. Because remember, the urinary bladder is in a warm, dark place. So when urine gets into the urinary bladder, it's considered sterile. Have any of you guys ever heard that, you know, if you like have an infection or something, like, anyone here ever got stung by like a jellyfish or man of war, right? Super painful, right? I told you guys I used to surf when I was a kid, so I'm always in the water. Man of war, I just got a piece of the barb. It scarred my face for a year, more than a year, from here, and down my left thigh, and that thing hurt. And I remember my friend Jojo was going, yo, bro, I got pee on you, and I'm like, no one's peeing on me. I know this thing hurts like the dickens, but what? Let's go to the aid station and get some saline and then pour it over so that it can decrease the toxin, right, of the poison. But Jojo was ready. He was like, yo, bro, I got you. And I'm like, no, let's not do that. But in theory, would it have worked? Yes, because
Only if it was sterile though, right?
yeah, urine is essentially, if you got your UTI going on, urine is essentially what? Sterile. But what happens when you keep urine sitting around for a while? It becomes what? There's bacteria in it. You can, even if you put a glass of water in this room, in about 4 or 5 hours, that glass of water will have more bacteria in it, 3 times more than it did 4 or 5 hours ago. So it goes just by sitting it around. And just imagine this is now in an incubator. It's in a warm, dark place. So of course, if you keep it there for a long time, which also the same thing for what? When you have samples, right? Let's say you couldn't get it to the lab. FedEx guy's already gone. The lab guy already came. It's after hours. What do? You put that, of course, it's already in, of course, the little sterile cup. You put it in the refrigerator. Don't put it all the way in the back, because what will you have in the morning? You'll have a popsicle. Is that acceptable to the lab? No. You put it like in the middle. I like putting it in the door of the refrigerator because the door of the refrigerator is a little bit, it's cold, but it's a little bit warmer. And of course, your refrigerator should be what? Biohazard and biohazard rated, meaning, do I put my ham sandwich next to, yeah, you know that, right? Every term goes in the other school. I come in and I look, the samples, we have blood samples, We have all this stuff in the refrigerator. Every time I'm like, I see a Gatorade bottle, or I'll see like somebody's sandwich, and I'm like, who the fuck put that in there?
We used to put it in like a bag and then just put it in the refrigerator, because sometimes that's the only refrigerator you got.
Yeah,
You're not supposed
but
to.
actually, according to OSHA, it better not be the only refrigerator you got.
I mean,
But in a mom and pop shop,
yeah,
a lot of mom and pop shops, they don't want to spend the extra electricity, because you guys who run businesses know that what? That's part of my overhead in my wife's mini mart. I didn't know how much, those glass refrigerators, how much they eat electricity. And I got 3 of them, right? Because of course I got a mini mart, it's all liquor, right? Liquor and Gatorade. So I go, same thing in a laboratory. But a mom and pop place, they're gonna be inspected by OSHA just sometimes. But if you're in a real facility, please, you see that biohazard sticker, don't you, I have some staff members, well, I only put it there for a couple hours, I'm gonna get it later. And then I tell my student, hey, do you know what's sitting right next to it? Poop.
Yeah.
Oh, this isn't a plastic, Dr. Grice. And I go, can I guarantee that the person who put it in the plastic bag didn't smear poop on the outside of that bag? Or I've seen this. Ever see a lab tech or a medical assistant? They carry the bags like this, like next to the body. Ew, no, you carry it in what? Something that you clean away from your body. Actually, in the hospital, we have a trolley. You're supposed to do it like this. But what do I see? I see people do this. Put it on, and then they dump it. And then people are, but again, what happens in a hospital? You start thinking about what? Turnaround time, you start thinking about your supervisor, and you forget what? There are rules and regulations, and there are ways to do things. This is the person we're looking for. This is the real nursing staff, right? They have their carts that got cleaned. Who cleaned it? You did, right? And you did what? And then you're looking at your log. Because if I do this, am I looking at my log? No. So could I have accidentally missed this? That did this? Fell out here? Oh yeah, when I was cleaning up, we were moving the lab of another campus. I was cleaning up the lab. You know what I found? Behind the refrigerator, behind the desks. Because of course, when they clean everything, they move these desks, but they don't move the big desks. I found blood, urine, sputum samples, HCG, pregnancy tests, throat swabs. I found everything, and it's just all sitting there. Thank goodness that wasn't my campus, but again, right? Cleanliness is actually not a virtue. It's actually the protocol at which you guys are at. And especially if you have a kidney patient, that place has to be super, super clean. Question.
Who?
You hear that question?
I was gonna ask, like, you were talking about the spasm earlier. So,
Mhm.
like, for example, and sorry if no one can relate, but like, you have to go to the bathroom really bad and you pee, but then like, it almost feels like your bladder's more full, even though you just.
Yeah, because what's happening? What's happening to the muscle? Remember, muscles contract, but when there's a spasm, it contracts, relaxes, relaxes, and that's where the pain comes from. Because and remember, it's transitional epithelia. So what's it gonna do? Like a balloon.
Oh.
And that's why you always tell, you always tell your patients, you always tell your kids, when you gotta pee, don't hold it.
So that's the
Go
spasm.
pee. And that spasm is really painful. I was at, what was I, Saturday? A friend of mine was DJing a skateboard demonstration, and I was there like all afternoon, and they didn't have any porta potties. And I didn't want to go all the way, to the store, so I just sat there for 8 hours, right? Then did my little thing, right? Did that, and then afterwards, I drove home another 40 minutes from Alexandria, then I'm home, right? Then what? I felt the urge, then what happened? You pee, and then what happens to the bladder? Shrink, and then what happens? Ouchie. And that's not good. Now, let's look at the urethra. Now, the urinary bladder, we already see here, and there's difference between male and female. If you look at the female, right, there's the bladder right there, and you look at the male, there's the bladder right there. Now, the urethra in the male, you see how the relatively long path it has to take for urine to go into the toilet? So it goes wee all the way down here. That's all. And of course, in some male patients, the pathway is longer than others, but let's not talk about that. But here, the pathway for my female patient is relatively what? Short. Now remember, urine is sterile, but look how close this urethral orifice is to my vaginal canal and my patient's anus. So the female patient, right, has a greater risk of having a urinary tract infection, and especially if they're children. Because what do children do all day? They scratch, and they sit down on what? Anything. They'll sit down on mud, they'll sit down on a whole bunch of things. And also, we also have to take in consideration patients of mental disease or mental defect. Are they going to clean themselves? No. So guess what we got to do? We have to make sure they get clean. So you could see here, right, the differences, but the same bladder is still there. Now, with the male, the other difference here is males have the prostate gland right here. And the prostate gland, when there's ejaculation and there's fluid, the sperm, there's cells. They have to have something to swim in. So the prostate gland provides that liquid medium for the sperm to go swim in. Now, you could see here that this thing is all nice, right? The tube is all well and good. But what if, odds are, male patient greater than 40, typically Caucasian, starts developing prostatitis. So what's going to happen to this tube right here?
Pinch.
It's all going to pinch, and what's going to happen to their ability to urinate regularly?
Decrease.
Decrease. Actually, one of your professors here, I don't know who they are, because I don't make any friends apparently here, right? I was in the bathroom the other day. Now, normally when you pee, what do you hear? And then dribble, and we're done. But I was peeing, then what did I hear? I heard dribble, like it was Morse code. It's like, right? And I was like, oh, someone has prostatitis, or some sort of beginning stages, maybe of benign prostatic hypertrophy, where that part of the prostate is what? Squeezing, right? And of course, I didn't want to look. I wanted to keep on, because of course, you look, someone's going to go pervert or something, right? But it's hard to sometimes to close my clinical ears. Same thing with coughs. There's certain, you'll learn in future training, there's different types of coughs. And one of those is that vesicular cough, when it's all the way from down here. You ever hear that cough that sounds like blah, blah? It sounds like there's wetness, and it sounds like there's a little smack at the end of it. That's a vesicular cough. That means there's a potential fluid line, and it's coming all the way from where? Deep in the lower respiratory tract. I heard one of my colleagues, and I'm like, and then I saw who it was. It was a much older gentleman. I'm like, someone needs to go to the hospital. Guess what happened then a couple days later?
He was sick.
He goes, he had to go to urgent care and stuff like that. Let's call him Bob. Bob had to go to urgent care. You see how bad he was coughing? And then my ear was like, yeah, I saw how bad it is. So it's really neat when you have a clinical eye and ear. Question.
And the pinching of the prostate gland and the
Urethra.
Yeah, also because is that like a prostate gland cancer type?
Yeah, you're gonna have cancer. Oh, by the way, all right, it was just only me and you, but also for female as well. There's a reason why there must be a digital examination of your rectum. So digital means what? Your digits, right? So if you see here, why in heaven's name would the physician or gynecologist want to put the finger here in the rectum? Do you see here? You see the cervix and you see the endometrium here. If there's any cancer or any problems, right? I could feel it right in here in the rectum. Same thing with the male. If there's any prostate problems right here, I stick my finger right in here, and what am I going to feel? I'm going to feel roughness. I'm going to feel a bump where there shouldn't be, right? So just know and understand, I don't want to stick my finger in those places that the sun don't shine, but I have to, Because why? Clinically, there could be some things there that I can't see. And you could see here that, you could see the muscles already here in your anus, the circular muscles. And you could see how you got this long one here, that's your external, and then you have internal ones, of course. Let's talk about this. No, we already, oh, look here. This thing also has rugae. Because why? It's transitional. Just, well, stomach isn't transitional, but stomach can be what? Small? Really, really big. Well, same thing with your urinary bladder. Really small, really, really big. And look at what we have here. Don't we have something covering it? Just like we cover everything? Everything in our entire body has a covering. So, of course, peritoneum is going to protect that as well. So with that being said, let's take a quick 10. And then for those of you playing at home, just fast forward through this next part in the 10-minute break. So just take 10. I'm gonna get some water. And then we're gonna wrap this up, and then we're gonna do question bank for next Wednesday's quiz.
Wait, wrap up this chapter?
Wrap up this chapter and then do
Question bank.
question and bank for this next week's quiz, so that we can all be ready. And hopefully you can skedaddle here at 3 o'clock.
Next week's quiz or
Next Wednesday. Next quiz is Wednesday.
So Wednesday.
this Wednesday?
Yeah, this Wednesday.
Okay.
Wednesday,
Wednesday's gonna be.
Chapter
chapter
18 and 19.
18 and 19, what we went on Friday.
17 too, I think.
Or 7, no. let me look.
I also haven't, wait, I haven't written down.
Let me look.
It is on Wednesday, it is, I don't have the chapters written down, never mind, sorry.
So those of you watching at home in this video, if you look at,
If I looked in the calendar, your announcement, that would be good.
yeah, you go to the announcements and let's look at that just to be sure, because I don't want to be misquoted. So I go in announcements and you go all the way at the bottom, like in the first day, BIO117. You click on that. There's a schedule right here on the bottom of it. You open it up.
It's 17 through 18.
And we look here, Unit 2, Quiz 1, and we look at Unit 2, Quiz 1, Chapters 17 and 18. So after we finish up, after this short break, after we finish up this this chapter, let's go through all the slides on 17 and 18, and let's make a question bank, and I'll make that
Okay,
bank available on announcements.
okay.
And of course, look at that summer break. So delicious.
Don't forget to get your water.
Yeah, I should get my water before I come to the desk. Okay, and I'll just leave this up for the viewers at home so that you can peruse. And also, don't take advantage of this break. Get a little, of course, rest, but of course, every day do a little something, because if you don't do anything and then do everything like the Saturday before the Sunday before you get back, you're gonna be what? You'll be dysfunctional, and then you're not gonna do well, and that's when the depression sets in. So let's not be depressed, and let's enjoy this wonderful break. What was I doing? Water.
Mhm.
What?
I'm sorry.
So he's giving us banks again, I guess?
I guess I've already done him. He said he wasn't doing it this semester, and I feel like he's done it I don't mind. you know.
I mean, we were talking about it earlier before you came into class, and I feel like he kind of has been taking your questions from your banks, you know what I'm saying? Because you make them with him, and then you send them to him. And I feel like his
I do.
questions, I thought you did.
I do my,
At least the first one.
I do my questions alone first.
Oh, but you send them to him though, to clarify if they're okay?
Yeah, so sometimes, if I have questions about it, you know what I mean?
I was gonna say, cause I feel like your conclusions are similar to his questions, but I guess you're making.
No, I literally go through each, I don't open my textbook, I just go through his, what he shows us in class. like
Yeah.
this PowerPoint, I go to the PowerPoint, and I look at each PowerPoint, and I'm like, all right, I guess I can make a question out of that. make a
Oh,
question out of
okay.
that.
Wait, PowerPoint or textbook or both?
I don't open my textbook.
Oh, okay,
I just use PowerPoint, because that's what he is teaching us in class.
okay.
So like, he's not gonna teach us something in the textbook that's, you know what I'm saying? That he applies. Be like, look, I already did chapter 17, this was only, like, that's all it goes.
Yeah, see, I don't know how you do that because like, I couldn't do that.
Chapter 17, yeah, you can, it's really easy, you just go to each by each, you know what I'm saying?
It's just like, cause earlier in class, he was like, how do you ask this in a Garais question? And I like had no idea.
What I was asking him that just then, before, I wasn't asking him how to make the question, I was asking him, if he wanted us to know
Yeah.
the, you know, the whole going all the way down, you know what I mean?
Helping for the other two items.
I mean, you can have my chapter 17 questions, that's, I can message it to you.
Or those what you make your concludes as.
Yeah,
Yeah.
but I figured some people need extra studying afterwards.
Yeah, some being nosy, so since this is my first time with him, you guys have a study group with him, or how do y'all? Oh, y'all go to tutoring?
Yeah, tutoring's usually like
If you're struggling in this class, I highly recommend
the tutoring.
tutoring. It'll like, it brought my grades from D's to A's.
And the Kahoot.
Yeah. But she makes those.
I make,
I'll base off those tutoring sessions sometimes.
Oh,
I like to go to tutoring sessions to see if I missed anything.
Yeah,
You know what I mean?
I feel like I don't need to go to tutoring, but like,
I like
It
to just
helps.
to hear it again and again.
you don't need to be there either.
Ooh,
You,
listen.
he
worry
told,
about yours.
he told you.
I'll worry about mine, okay? I'm being there, and I'm there, because I feel.
It's the same.
I'm up in there.
He also does see, like, nice to like, it's like,
You can take me on too. If I don't have 100, then I can hand it.
He always lets us know. You can email him and ask him. He has like, he does them on Tuesdays and Thursdays.
as far as Kahoot goes,
He's
y'all,
pretty
I
accommodating.
already have 17 Kahoot time. We can practice 17.
Yeah,
I'm
but
not
if you're
gonna do
like,
18
my tutor at 4 a.m., he will 100% do that. I promise you.
I was letting you know that I'm doing a separate now. I'm doing each chapter is a separate Kahoot. I'm not.
He records some of them, though, puts them online.
Why not matter?
No, it's actually
Like 50 questions, she had it online.
Yeah.
It's 50 to 52.
Was that just 66? Oh, 'cause I don't know what's on
How's
here.
your coffee,
You know
Cleo?
what I'm saying? So it's-
How's your coffee?
But, when I was doing it, it's that up top.
You feel better or you like
But
it
it wasn't
better?
the whole 52. Yeah,
I'm more awake, but.
Yeah.
it was more like 40,
Yeah, you don't like that.
47, 40. around
And
there.
see what yours is.
Yeah.
I don't know, but regardless, I'm doing each, the rules are not, I'm doing in per chapter now, I'm not combining. I mean,
Yeah.
so if it's an exam, it's gonna be, you know, it's exam like 2 chapters for that chapter, you know what I mean, for that exam. Before I was combining it, it was like 100 questions.
Okay.
Oh, yeah, that's right, you can write,
I did it for that one exam, and it was a lot, so I'm just gonna do it by chapter.
Yeah.
Let's make it.
You got one from.
It's the fountain.
There's that, refillable one, not just like the one you drink out of.
Yeah, the thing that told me put the senses in.
It's by the bathroom, by the cafeteria.
Oh, okay.
Yeah.
I'll show it to you. I went
Ooh.
to the website.
Nothing. Oh. Meds are wearing off.
Your gout ones?
I have a question. So, Professor.
Yeah.
As we look at the schedule, we see that we have a midterm on Wednesday. Is that midterm or
Midterm for
lab?
lab, midterm checkoff and midterm lab exam is for lab people.
Okay, that's what I want to know. So when would our midterm be for collection? Would that?
Well, we don't have, we have exams. So midterm for exam, probably when you get back, because we need at least 2 exams out, so. I don't know.
We don't have.
We didn't have one for, we had one for last term, but for this one,
No, we don't have.
last term,
We didn't have one last term,
we didn't have one?
not for lecture, no.
I don't.
Oh, fine, so you don't have one then.
Hey, so the, for the midterm lab exam, are you posting every picture that we're supposed to know on something or?
Yes,
Okay.
you saw that I did it
I
for
saw that we
week
did it for
1,
that one.
and I'm gonna do it again Thursday for week 2.
Okay.
For those who don't have to take the lab, midterms, okay, this is something I don't have to cover.
No, anything in red there, that's on, that says exam 1, 2, 3, and 4, that's you.
Okay,
Unit 3, quiz, anything that says quiz, that's you.
so quiz,
But those 4 things on July 6th and July 20, that's lab people.
okay, so this one,
So don't, I wouldn't worry about it.
and then our exams here are cumulative. collective.
Well, if you look at the bottom part of this document, this is the scope of your exams.
Okay,
But your final exam is what? 14 through 24
okay,
is everything. And then we'll have we typically have a grand review, either like the 20th or the 21st. But again, now that I know how to record on Teams, I'll record it and then put it so you don't have to come in.
okay.
And if any sample questions come out of it, I'll post it on announcement. All right. Now that we got that out of the way, well, what is it? What am I doing? Go back to, so now that you see some movement on the video, now you can go back to, hit play. And we're now here, urethra. Now, if we look at your urethra, again, it's gonna look familiar. They have coats, and these coats also perform peristalsis. So you have the innermost coat, which is mucosal. You have you also have underneath that mucosal coat some more glands. Now, what's important about the urethra, other than it's surrounded by smooth muscle and then performs peristalsis. The ureters and the urethra perform peristalsis because we want to push we want not only the urine to come down, we want it to come down efficiently. And just like the anus in the gastrointestinal system, you have internal and external. Now, the external, of course, is skeletal muscle. You can control it. The internal urethral sphincter is smooth muscle. You cannot control that. And remember, just like the gastrointestinal, who's going to win eventually?
Involuntary.
The involuntary smooth muscle will eventually win. So you can try to hold it off as long as you can, but you will eventually what? You will eventually need to urinate. Now, if you cannot urinate for whatever reason, let's say, for example, I had a patient who had saddle injury, S2, S4, they couldn't pee. So the nervous control to the urination and to the skeletal and smooth muscle was damaged. So complaining of hypogastric pain, increasing hypogastric pain, and because of what? And then I asked him, hey, when's the last time you peed? Because when I put the catheter through, nothing for like 2.5 hours.
What do you mean nothing?
Nothing,
Like
no,
urine?
no urine, but he's young. His cardiovascular was good. And I'm assuming what? His kidneys are good too, but he has a saddle injury. He had a motorcycle injury. So what did we have to do? I have to take this huge needle and then I got to put it where? Right through his pelvis and into his urinary bladder, and then we could empty it out that way. Oh, at first he was like, kind of like freaked out that I have to stick a big needle so close to his penis, but the pain was excruciating. So once we evacuated all that, I was done. And then of course, nephrology came in, and then they were able to do what? Get the catheter a little bit deeper and then do business. We already know the differences between male and female, and of course the male has a prostate, female does not. Now, what's another word for urination? Another word for urination is voiding.
Elimination?
Elimination is another way. Elimination is more of like a generalized term for urination and defecation.
Okay.
But urination is, but you could say elimination as well. But micturition, urination, voiding, that's all the same thing. And of course, there is a micturition reflex. Remember, the urinary bladder, I can't control that. Well, another thing the urinary bladder has is mechanoreceptors. It senses that it's all full. And when it senses it's full, it's going to send a reflex where? To my spine, and my spine is going to tell the muscle to do what? Squeeze. So the sensory is what? Mechanoreceptor, I'm full. Reflex, does it involve my brain? Nope. So when your bladder gets full, your body will tell you, right? And of course, that's when you get the sensation to want to void. Now, I just mentioned that my patient had a saddle injury, S2, S3, S4, which is their sacral 2, sacral 3, sacral 4 nerves. That's where the micturition reflex center is in your sacral spinal cord. So if I damage my sacrum, and one cool way you can do that is, get on a motorcycle and crash it. And then it'll hurt your stuff here in the nether region, and it might either permanently or temporarily damage your sacral spine, and that's your micturition reflex center. That's the center that tells you to do what? You need to go pee, right? But of course, I have external sphincter that says I can hold it, but who's eventually going to win? The internal urethral sphincter. So now let's go to that incontinence question. What happens when I cannot control micturition or voiding or urination? It's because of what? It could be what? The muscle could be damaged, right? I had a friend of mine. He was like, it's a tough kid, got into a really bad fight, and somebody mashed his testes and his penis with a bat, right? And after they fixed them all up and everything like that, he wet himself for like, I don't know, the whole summer at least, because we were in summer school together, and he kept on wetting himself. Because why? He has what? Damage to those muscles, damage to those nerves. So can he control peeing? No. So every once in a while, he'd be like, oh, damn. And it became like a normal thing. After the first couple of chuckles that we had in summer school, like after a week or two, we're like, yo, Brian, man, you wet yourself. And he goes, oh, damn. He'd just sit there. And he would like, and then I had to go for English, the irony of it all. I'm really good at English now, right? He used to rip pages out of the English book and just put it down his pants to like absorb all the urine. It's just a bizarre thing. I haven't thought of that in years.
So he didn't feel it happen.
No, because why? All of that is damage. So he didn't feel any urge, didn't feel anything, but he'd be like wearing shorts. And then of course we'd see a little puddle next to him and we're like, yo, and he goes, oh, and anyone here ever in summer school? Yeah. Teacher don't care, right? No one cares. You just got to do your time, right? As long as you don't cause any trouble and you do whatever stupid little assignment they make you do, right? So you just sit there. So the whole day we just sit there and like maybe read whatever we want to read or do it. But it was English. We had a really cool teacher. She let us read whatever we want to read as long as at the end of the day we wrote a couple of paragraphs about it. Which actually, don't you think it was nice? Because then even though I got left back for English, what did it make me do? Practice something I'm not good at. How do you think I got into college? I became a really good writer, right? But my freshman year in high school, and 8th grade, no, wait a minute. Freshman year of high school, I got left back, not left back, I had to do summer school for math. And it was 8th grade, I got summer school for writing, for like English writing. Because, you know, like I said, 14-year-old Nelson, was he too bright? No, he'd rather hang out with his friends and do stupid things than what? Go to school. And you know, New York State public schools, you have to do the minimum hours. They really don't care less, but if you don't do the minimum hours, if you're just under like a couple of hours, they make you do the entire summer school. I wish I knew that. I should have just did what the time. But with poor Brian, his micturition reflex center in his sacral spine was what? Damaged, right? So you have something called enuresis, and that's another word for incontinence, and that's bedwetting. Now, enuresis, nocturnal enuresis, when you pee at night while you're asleep, that's a whole different ball of wax. So it could be what? It could be psychological, or it could also be neurologic.
What, like dreams?
Like it could be dreams or stressors. There's a whole bunch of things that would make you wet yourself. I remember one time, I was in my 20s. For whatever reason, I had a dream about state wrestling finals. And I did what? I had a dream that I was at the urinal and I urinated. And then I woke up. I was on my friend's couch, wet. Because what did I think? I guess I was like kind of half asleep, half awake. And I thought, what? Time to pee. And then I wet myself. And then my friend got really,
Telling you to wake up?
I don't know. But to this day, isn't that nocturnal enuresis?
Yeah,
And for a psychological reason, I was thinking about what?
okay.
One of the most stressful days of my life, which is state wrestling finals when I was a senior. Because I went to a sports high school, and you know what they do. Anyone here went to a sports high school? But you didn't play sports. You didn't win. You're what? There's something wrong with you. And then everyone made fun of you, and then it's not fun, right? And also the pressure. At that time, we were the 38th year of making states. So are you going to be the senior class that doesn't win? I win 38 senior classes before you, won. So to a 17-year-old, what kind of pressure that is? So is it any surprise that I thought of that and then did what? You know, team myself, right? Or it could be fear, it could be all a bunch of things, or I don't know, my duking, my 20-year-old, he every once in a while he wets himself and he admits, I could have made it, Papa, but you know, I just rather just be here. And I'm like, but of course he's a Marine. What do they do all day? Do you leave your post? No. So if you got to pee or you got to squat, what do? You pee and poo right there. Because do you want to leave? Oh, one of the horrible things in a Marine's life is to get killed while doing a combat drop. You know what a combat drop is, right? It's when you pee or poo, right? Imagine you got your drawers down and then you're in the most vulnerable, and then what? Zap! You're in heaven wondering what? Oh man, all I wanted to do was do a combat drop, right? And then when you do a combat drop, what? A whole bunch of your buddies have to also come with you. Make sure no one, because don't you think someone can grab you up? Yeah, because our troops are fighting in an urban environment, so that's their backyard, so that's their alleyway. And if you don't think they're sitting right next to you, then that's your first mistake. Well, Duke had now the habit. I caught him like I think a half a dozen times. Like, why is the couch moist? And he was like, oh, sorry, Papa. And I go, quit being lazy. You're not there anymore. You're here now. So you can only now imagine what? How is he going to be when deployment's over? When it's all over. It's all over for him in the next 2 months. How's he going to be when he comes home? He's going to have a lot of things to fix, right? You guys have family and friends who came back and they were in forward units. Even if you're not in a forward unit, the level of paranoia. How many troops, especially an 11 Bravo or an 0311 Marine, has to sit with their back towards the wall? They have to be in sight of what? The door, right? Or they got to be near the door. My nephews have a thing about that. When we're in the restaurant, they scope the restaurant and goes, we need to sit over there. And I go, why? Bar's over here. right? He goes, this is where I'm gonna get my lovely soda. He goes, no, we gotta sit, and it was very isolated, but then I noticed I get a clear shot of the entire Cheesecake Factory from where we were sitting. And then I'm like, come on, you two. You know when's the last time they had deployment? 2 years. So it's been like 2 years and they're still what? They're still there. They're not here. They're not normal anymore. So that also can be what regarding nocturnal enuresis and these other things. It could be stressors. It could be what? A whole bunch of other things. And no one understand. You're here in Virginia. How many vets are you going to have as patients? You're going to have tons. So you're going to have to understand how they think and how they move and how they act. So let's look at lifespan. Let's look at this depressing lifespan changes that are never happy. It never says you're going to be a superhuman. It never says, oh, you're going to pee gold or whatever. All right. It's always something. Kidneys appear scarred and grainy. Ugh. Because, of course, damage, fat, and connective tissue accumulation. And, of course, pee, don't pee, right? Hypertension and, of course, beginnings of diabetic nephropathy. Don't you think kidney cells are going to die?
Yeah.
Your JG cells aren't that that stuff. And look, by the age of 80, and remember, a lot of people are going to live way past 80. Kidneys have lost a third of their mass. I didn't know that. I didn't need to know that today. But now why? What happens? Your GFR gets less and less and less. Actually, there's a sliding scale for GFR in both urology, which is the study of what? Urine, and also internal medicine. So when I look at the GFR of different patients, especially above the age of 55, I got to calculate for what? They're older, their GFR shouldn't be that efficient. Tubules thicken, you could have proteinuria. So is it a good idea to kind of lay off the meat? You get older? Yup. Reabsorption of nutrients and ions become less efficient. Harder for the kidneys to clear certain substances, especially meds. But what do we have when you get older? More meds. And that's the conundrum. My liver and kidneys and nothing works as well, but I need them to process the meds. But when I get older, I get more meds. So it's like this catch-22, you know? And that's why I hate, not hate, that's a strong word. I have issue with polypharmacy with a patient with a lot of meds because it gets complicated. Blood flow, of course, because of your heart. And in general, it's going to slow. But let's say you do what you need to do to keep your cardiovascular on. Then how's your kidneys? As long as your cardiovascular is good, kidneys are good. As long as the blood flow is good, right? Which also relates to our diet, which also relates to diabetic control, or pre-diabetes control, right? What's easier to filter? We already said this regarding pump. Water or molasses?
Water.
Water. And sugar. Isn't sugar a big thing? That's like throwing rocks at a screen. So what's going to happen if your whole entire life you've been drinking soda all day instead of water? That screen is going to start to fail. And then you're going to start to see things in urine that you shouldn't see, like sugar, proteins, blood, and the such. Bladder holds less urine. That's so true. Kidneys are less able to activate vitamin D. And isn't that very important to women, right? Yet another thing to say to you, I need to upgrade my calcium. And last but not least, loss of bladder control, because how's our brain, right? How's our nerves? They don't get better during time, they get a little bit worse. But what do? You pee when you have to pee, you don't hold it in, you get to practice more, you get to hold your incontinence. But again, right, eventually it's going to give in. That's why I made the facetious joke a while back that, oh, we should all invest in Depends undergarments. And yes, you should. If you're looking for investment opportunities, start looking at, look at this article. It's called The Graying of America. I forgot where I read it, but it shows statistics where we're living to well into our 90s, and like my mom's in her late 80s and she still walks around, she still drives, she still talks. So will I be surprised that she reaches 100? Will I be surprised I reach 100? I was okay with 40. But now with technology, with meds, with everything that we now know, people are living a lot longer. And also, if you got to live a lot longer, how's retirement? I laugh when my friends start talking about retirement. Like, I'm gonna retire at 59, I'm gonna retire at 62. If you're gonna live to 100, that's not a good idea, right? Do you think you have enough? I don't care who you are, you think you have enough for 30 years supporting you? And also, you can trust your kids to support you? Because what happens to kids? They grow up, they have families of their own, right? So, yeah, it goes, I like that my adult kids are growing up, they're being independent, but do you think, even if Chanel became a doctor, do you think I could rely on her? Right? She's gonna have debt up to her eyeballs. So she's gonna have her own life. So I have to now start making plans. Well, actually, I started in my early 40s. Start making plans to do what? Every paycheck, put a little away. And then once you have your a little bit, what do? You never spend the whole principal, but what do? A little bit, find these investments. I read this wonderful book. It's called Financial ATMs. Right? You guys know I got little businesses, right? They're not making thousands and thousands of dollars, but every week they're handing me what? A couple $100, right? How many times when I have to go eat out, I don't feel guilty? How about for dry cleaning? How about for gas? Do I got to worry about any of that? Nope, because my mini mart, Star Tree Sounds. I also have I have my nephews. I have them running a reselling business. Everyone in other countries loves American stuff. So you know what I do every Thursday? Me and my nephews, we go to like Goodwill, Ross, and whatever. And there's certain products that Filipinos in the Philippines love. You get it, you send it in a box. It's $80 for that box. I can make $140 off that box. So I pocket what? 60. I give the 20 to the kids and pocket 40. So let's say I do 2 boxes every 2 weeks. Can you do the math? Right? And now my mini mart, I can sell that stuff in my mini mart too. You see what I'm doing? I'm making ATMs, incomes. It's not a lot, but it's gonna, do I have to work it? No. It's working for me. And then what am I doing with some of that other income? I'm putting it aside because my other thing now is commercial property, right? Parking lots, right? I'm waiting now, what? Now that COVID messed everyone's stuff up, now everything's up for the grabs. So I go to auctions and whatever, buy cheap, sell big. See how this goes, right? And that's how rich people think. We think like normal people like me. Normal people used to think this: what? I get a really good job, I get a really good education, pay off my debt, work until I'm blind. That's wrong, right? You work because you like to work, right? Work, and that's why you guys chose what? This profession, right? I hope you didn't choose it for money, but you chose it because it has longevity, I can improve upon it, and some of you in here chose it for financial reasons because it will enhance your business, right? So it goes, you guys are doing it the right thing. How many of you went to a traditional college and had to take all these extra classes? I took 4 comparative religion courses in undergraduate. How in heaven's name, pun intended, is that going to help me? Sure. Did I read the Ketuvim? Sure. So what? I'm going to be Jewish now? No, that's not how it works. Education should be what you guys are doing. You're taking knowledge and then doing what? Monetizing it, right? So take advantage. Even your core classes, you might not think there's little nuggets in your core. I looked at your curriculum because I'm very, very interested in core class. I used to teach a similar class in the other school, and I'm very interested in it because I'm very interested in the study skills section, and I also got a couple of lectures on memory. I have a horrendous memory, right? But what have I done to my long-term memory over time? I've made it what? Better. So I can memorize as much as I can. So now I get off my soapbox. Now what can we do? We can now what? It's like 1:45. So let's take like 30 minutes, 40 minutes, and let's do question bank. What's our Wednesday quiz? 17, 18?
Mm-hmm.
All right. I promise no more question banks, but hey,